Oh, nice. I'll make sure I don't block that.
Yeah, no worries.
I don't know actually who just stuck that up there. It's like it appeared out of nowhere.
Nick is here. Nick. Oh, really is deaf. Nick. We were just screaming the names.
A lot of people have it.
Reach people to win this fight. So please sign in if you didn't get a chance.
Oh, please. A lot of people have my name. Sure. Yeah. They're on a lot of Dorian Grays. We're good on that end. Focus on release. Insured through the ACA. Medicaid expansion. People with HIV already on the noise. Hi. Yeah, I gotta raise my hand and first thing up. Excuse me. You know how much HIV meds cost? Why no mention? Oh, it's an oversight. The next us, we promise not to heckle much.
How you doing?
Good, and yourself?
How was your New Year?
It was good. And yours?
It's good.
The kids?
Yeah, the kids nonstop. My husband's been working because, New Year's. Restaurants are kind of busy.
Oh, yes.
So
Where is he?
he's at Wayfair.
Okay, still.
Yeah. He'll be there for a while.
Okay. Groovy.
Yeah, but it was a bit a lot of me and just alone with kids. I love them, but it's a lot.
A lot to handle. I'm not a parent, but I know many parents, and they love their kids, but they also go, they're driving me insane.
Yep.
Oh, man. Oh, cool. So I don't know if y'all, do you know Glenn?
No. Hi. Nice to meet you. And I'm currently blanking on your first name. Michelle.
No worries.
Dorian.
Nice to meet you. I'm with Our Revolution in New Orleans. Got a little branch going, and we're holding a rally on January 15th for vets to, kind of raise
Yeah, I don't know if
awareness.
change. I didn't even think about bringing change in. of change we want to do. Be interested in, or land.
Well, since I represent change, yeah, change is on board for anything that's reasonable.
This
So
is more of a
at your
rallying
rally,
call.
Yeah, I'm not big on that
Me neither.
because
Yeah.
you know a bunch of folks get out in the street.
It's just a way to kind of bring attention, you know, visualize, bring attention to the whole subject.
It's really because Sanders called for it.
Yeah.
Right. That's
Yeah.
just.
Senator
Sanders.
Bernie Sanders.
Yeah, but he didn't win.
No, he didn't win, but he's still fighting.
He's doing a
I'm
town
back
hall
on
on
winner.
Monday.
I want to make America greater.
Whoa!
Let's just stop at great. Let's go to great.
Greater. Bestest.
Bestest. Big league.
Make America
We're going to make America big league.
Hey, we're gonna make America something.
Yeah, well,
Don't know what it's gonna be.
before we implode it.
Yeah, it's pretty scary right now.
There's some lawyers doing some last-ditch efforts to not have him inaugurated, and it seems so desperate.
It is.
There's no.
It's so like,
I think it was one of George W. Bush's legal counsel or whatever is basically like calling out like all these unconstitutional things, like they'll be in violation of the Constitution day one. I'm like, come on, hopefully.
yeah.
But what does that even mean, you know, really?
Apparently, a lot of the electors were illegally sat as electors.
Do y'all have enough things to read and hold?
I'm never on Facebook.
So do y'all have enough things to read and hold? Great. Can you pass that?
I'm never on there. Thank you. Take one, pass it down.
Thank you.
By state exchange. State exchange with marketplace.
Yeah. So state impact.
It's not an exchange except in Arkansas. Okay.
We use it.
Sure.
Started a few minutes late, but it's a great turnout tonight. Thank you for coming out on your Thursday evening to learn about what's going on with the ACA. First, I want to first I'll introduce myself. I'm Jeannie Donovan. I'm a policy specialist at the Jesuit Social Research Institute at Loyola here in New Orleans. And we are one of 5 sponsors of tonight's event. The other 4 are the Advocacy Center, the Louisiana Budget Project, 504 HealthNet, and Voices of the Experience, or both. A brief overview of the agenda before we get started. We're going to hear from individuals who have been personally impacted by the ACA. We'll also hear from an expert panel on the importance of protecting this law and what you can do, what we all can do. And then we'll also hear from the public for Q&A and sharing of stories related to the ACA. Importantly, tonight is a call to action. We're going to take some steps tonight, but we've also provided you with the tools you'll need to continue to be an advocate going forward. And really the overarching idea of the evening is that it's essential that our federal representatives, our congressional delegation, 3 of which are up here on the board, the 3 that represent New Orleans, with the exception of Representative Richmond. So this is their contact info. You've also got their Twitter handles on your handout, so please feel free to use those throughout the evening, but there'll also be, in the future, there'll also be a specified time at the end of toward the end of the event for a Twitter storm, and we'll talk more about what that is when we get there. We're going to start off with a personal story from John S. Williams, who is a self-employed attorney here in New Orleans at the law offices of John S. Williams. He's a graduate of Xavier and originally from Jackson, Mississippi.
Thank you so much. I'll stand. I like to talk on standing up. It's a pleasure to be here before you just stated, my name is John S. Williams. I am an attorney in private practice. My law firm is located at 4164 Canal Street. Plug, marketing is always important. But I'm here to give a testimony about how the ACA impacted me. I graduated from law school in 2004. About a month after I graduated from law school, I was diagnosed with multiple sclerosis. Does everybody know what that is? Okay. Well, for all those that don't, multiple sclerosis is what doctors would call a degenerative neurological disease. In English, what that means is that my immune system basically attacks my neurons, pretty much. It really impacts my muscles. Many people have had it, as we might know, anyone had it before. Richard Pryor, really funny person. But the way it impacts you is it will, over time, and many people, it will impact your muscles. So your muscles are your eyes. You might not be able to see. You might not be able to walk. You might need to walk with the assistance of a cane. It might fatigue you to the point where you cannot work and you cannot really move. So it's a really serious disease. When I got diagnosed in 2004, I was uninsured. At the time, I had a hospital stay of about, I think a week and a half, about 10 days, which you can probably imagine what the medical bills were, about $20,000. And at that point, they just had to charge that off because I had no way to pay it and nobody to pay it. Over time, I was fortunate enough to have went to law school and I was employable. I could find a job. I had great credentials, great contacts. So I said, all right, I have this disease that has to be treated, so I need to go find a job. So I found many jobs, and I devoted much of my professional life to helping people and to fighting for people. I worked as an attorney at the ACLU for many years. I worked as an attorney at the Juvenile Justice Project here in New Orleans for many years, trying to assist. Over time, I felt like, well, I could do a lot more not working within the framework of organization and just working for myself and being able to make my own shots and determining the folks that I want to help. One of the biggest barriers outside of the natural barriers and, you know, not getting a check and having to go and feed yourself is insurance. I got the invoice for my medication that I take. Pretty much I take one shot once a week. Throughout the course of the year, I need to go get MRIs because MS manifests in the brain and the spinal cord. So you take MRI to see how it's manifesting in you. I got the invoice for my medication, and the medication costs approximately $6,000 per month. Pretty much, I'm uninsured. It doesn't make sense for an insurance company to insure me because it's just a money grab from the beginning because they'll never get their money back. The way I saw that is when I was thinking about leaving my job in 2012, I figured out I'm not going to be able to get insurance, pretty much. And without insurance, my health is going to be drastically impacted. I went without medicine for 1 week, and after that week, I have had to go and check into the hospital because it impacts you like that. MS is becoming a disease much like diabetes, where they want to make it treatable. But without the treatment, you're really going to be in a bad situation. So after I left my job in 2008, for a while they had Cobra. Cobra was really expensive, which is, you can imagine, for a person that's starting a business, it is somewhat unaffordable. But with a person with a chronic illness like myself, it has to be affordable. So I had Cobra for 2 years. After Cobra ran out, I was kind of like, okay, now what? Fortunately, because MS prescription medication is so expensive, certain companies have programs that will assist you with getting the medicine. You still have to pay for it, but it's assistance. But the problem with that, of not having health care, you don't get an opportunity to have an MRI. You don't have a primary care physician to be able to check all the other things that might, go wrong with your health. And you don't have a chance to have a neurologist, which a neurologist is really important when you have any disease that impacts the brain and the spinal cord. When the Affordable Care Act came about, I was like, yes, I was all about it. And I was able to get insurance just like that. It was like I didn't miss a beat. I had pretty much the same insurance that I had when I had a job. When I worked for the government, I worked for a nonprofit organization or a private company. I had the same insurance. I was able to go get a neurologist, I was able to go get a primary care physician, I was able to get my medication, I was able to get everything. Unfortunately, with all the rhetoric going around the country now, they're talking about dismantling the Affordable Care Act. And this makes me feel terrible for many reasons. Firstly, from a health perspective, I know personally from things that have happened to me with my multiple sclerosis that I absolutely have to take that one shot per week. I have to do that. I absolutely have to go and see my neurologist at least once to twice a year to see how I'm progressing. Outside of multiple sclerosis, I really need to have a primary care physician, because 9-10 years ago when I got diagnosed, I was in my 20s. Now I'm approaching my 40s, and God willing, I get on up to 50s and 60s, and I know I'm gonna need health care even more than that. Important, but not most important, I work for myself. One of the biggest aspects of my life now is I can help other people to support their families. I hire people. I can assist people with their cases. People that don't have the money to afford me, I can help them too. Those type of things I could not do if I worked for a corporation, a company, or organization. Those type of decisions are made at that level. It is important to me both professionally and personally that I have the ability to make the decisions of who and who not I want to help, what causes I want to support, what causes I do not. That luxury I only get by doing what it is I do now. It's one of the most fulfilling things I've ever been able to do in my life. Without the Affordable Care Act, I cannot do it. In the event that it was to go away, I probably would be looking for a job and closing the doors of my law firm that has been open for 5 years now, and it's been a really awesome 5 years. So I really, as I said earlier, appreciate the opportunity to come here and tell my story about how the Affordable Care Act has impacted me, and to hear more from our panel of experts about how we beat back the ties of what all these individuals are saying that they want to do too. Thanks so much.
here in the community to care for everyone. And a lot of work that we do is around outreach and education, and to make sure that everyone has insurance and that they have a primary care doc and they can get connected to behavioral health resources. So if you or someone you know is uninsured, I'm going to have Danny and Diamai raise your hands back in there. They're two of our lovely staff members, and they have some information outside, and you can talk to them about how to get covered. And again, if you or someone you know doesn't have coverage, it's really important that we do make sure everyone in our community has coverage. And there are people who are not eligible for Medicaid or insurance in the marketplace, like Mr. John. And we do have other options and resources. There are other programs at the health centers, and so if people who don't qualify still need care, we can get you into care and into the clinics. And so it's really important that we continue that message of making sure people realize we do have clinics and we do have the ability to care for everyone in our community. So today I'm going to talk a little bit about the Affordable Care Act, resources in our community, and kind of what you can do to help. So I think sometimes people really forget about what what it looked like prior to the Affordable Care Act, prior to 2009, and what our health system nationally really looked like. And the reality is that if you didn't have coverage through your employer, so about 55% of all Americans got coverage through their employer, and if that wasn't an option for you, then it was really hard to get coverage. If you had a pre-existing condition, you were denied. I used to work for the federal government, and we looked at different plans and different things, and health insurance companies would deny people coverage for being diagnosed with acne, literally. So you're looking at the ability for people who need care who couldn't get into care. And so the reality is we had a system that was based on insurance, and if you didn't have insurance, it was really difficult to see a doctor and really expensive. And the way that the United States has set up for care through the Medicaid program prior to the ACA, in Louisiana in particular, you had to be really poor and have children. There also were some categories of people who were blind, disabled, certain cancers, etc. But the reality is that for a family of 3, your income had to be less than $3,000 a year to qualify for Medicaid. And so you're looking at a lot of people who didn't qualify, but who still didn't have insurance through their employer, and so really couldn't purchase it through the individual market or the regular marketplace. And so we were left with a large number of people who couldn't see a doctor. Also, you see a lot of charts in here about increased costs. Actually, under the ACA, we've seen a decrease in costs of what we had initially thought. So without it, I think that message sometimes gets lost in the news and the media, that we're actually seeing a decrease in what was originally projected. So under the old model, we did have care provided through hospitals, and under our current model with the Affordable Care Act, we have insurance. So the money is going, and the insurance product is following the people that then go to the physician to get care. So I know a lot of people here in the news, you're for or against the Affordable Care Act. It's a good thing, it's a bad thing. It's a terrible law, it's a this, that. It's 900 pages. So the reality is that there are good parts and there are parts that need to be strengthened. And so I've outlined, I have 11 things between this and the next slide that I'll cover that really are sort of what the Affordable Care Act is about. And the overall goal of the Affordable Care Act is to improve access to care. And it keeps our existing model of saying we're going to have a health insurance system and everyone's going to need a health insurance card to make access easy and affordable. On the other spectrum would be something like universal coverage, like the model through Europe and Canada that a lot of people I'm sure have heard about. And that's sort of the other end of the spectrum. But the Affordable Care Act came in and said, we're going to keep the system we have, but we're going to make sure that everyone is in the system. And so in order to do that, you have the individual mandate, which requires people to get coverage. You establish the marketplace, which is how Mr. John has coverage. So you're looking at creating a new insurance product or a new way for people to get coverage. And then it's also subsidized, and that's tied to your taxes and your income. So people who have a lower income get a higher subsidy. People with a higher income get a lower subsidy, so that it's scaled for affordability. It also expands Medicaid. So if someone who is working 40 hours a week and who's uninsured and is a single person, they now qualify for Medicaid. So that before wasn't the case. So if you're minimum wage, working 40 hours a week, and you don't have coverage through your employer, you now can get covered through Medicaid, and that's huge. We know in our community we have a lot of people who work construction, who work the service industry, and who don't have access. And so through the marketplace and through Medicaid, it really opened up doors and made available a way for people to get coverage. The Affordable Care Act also creates the ability for insurance to not be able to deny coverage. So the pre-existing condition that we heard about of where, like for acne, they would say, no, I'm sorry, you're uninsurable. And that really isn't what we want our insurance market and our community to be about, where you're able to deny people based on sicknesses that they can't help. Children can stay on their parents' plan up to 26. And it also has some market regulation around making sure that insurance companies have to spend the premium dollars they collect on actual care. So rather than say, let's jack up premiums and then keep those as profits because we're private companies, now the U.S. government is regulating and saying you have to spend some money on care. And if you don't do it, then you have to refund it and give it back to people. Prior, there were lifetime limits, so the insurance company would say, guess what, we're only going to spend $100,000. And if you happen to get cancer or if you happen to get something that's really costly, once you hit that limit, too bad, good luck. Go figure out how to pay for it. And so now we're saying, you know what, guys, you can't do that anymore. So by bringing people in, we're creating additional dollars that come in as premiums. So we're making sure everyone's in the system, and then you're able to make some of these changes so that people can get the care they need. Again, preventive care is free, so you can go and get your wellness visit once a year, which everyone should be doing. So go to your doctor once a year. There's no copay associated with that. And then women are not charged more than men, which was an issue before. And also, the law has a lot around quality and health systems improvements and initiatives. So looking at this slide is, and I apologize, it's a little small, but essentially what it really is just saying is that before, under Medicaid, we had people who were left out, childless adults, and people who made some money but not enough to qualify for subsidized coverage through the marketplace. And that, really what you're looking at is trying to figure out this picture that if you don't have employer-sponsored insurance, how are you going to get coverage? And coverage is really built on your income and your family size. And so looking at, prior to Medicaid expansion in Louisiana, we had people who had traditional Medicaid, and we had people who could get coverage through the marketplace. And then there were a bunch of people left in the gap. And the bunch of people, it's actually close to 374,000 people that we have in our state enrolled in Medicaid today. And so if the ACA goes away, those 374,000 people will lose their coverage. And they will be stuck without an option. And they will be stuck without the ability to go get their prescriptions, to go to see a primary care doc, to manage their diabetes, their hypertension. And that's really impactful. I mean, these are people who have jobs and they don't have another option. And so how do we make sure that we are creating the ability for people to get the care they need? Looking at, so why are we sticking with this model? Why are we trying to expand coverage? And it's really about creating access, building primary care out so that people can manage their illnesses sooner and appropriately in a lower cost setting, and then being able to reach out through that primary care doc for the specialty care that they need. And so the way that we've built this is if you have that insurance card, it makes it a whole lot easier and a lot more affordable. Without that insurance card, things get a lot more difficult. I think looking at the positive impacts for our state, and John's going to talk a little bit more about this, but with the Affordable Care Act and with Medicaid expansion, you're looking at stability for the healthcare system, additional dollars flowing into our state, so it's additional jobs, and also it's really better for our economy and businesses. So untreated health problems cost employers $380 billion a year. And so that's for if someone's sick and they can't go to the doctor for their diabetes and they miss work, that costs employers, it costs our economy. And so looking at how do we build a healthy and effective workforce, insurance is all part of that. Medicaid expansion in Louisiana, I mentioned the 374,000 people, and what's been interesting is in 6 months, we've had 1,000 people who have received colon cancer screenings, and those 1,000 people, so actually we've had more than that receive the screening, but 1,000 people were able to have that treated because of Medicaid expansion, meaning they didn't develop colon cancer. And so you were able to treat that at a lower cost at an early setting and really catch that ahead of time. And that's just in 6 months. And so thinking about how we build a healthy population, recognizing that people need access to care, and looking at what Medicaid expansion, it's not just a card. We've actually brought access and treatment and care to people, really impacting lives. 58 women have been diagnosed with breast cancer as a result of imaging that they got through this program. And so it really is affecting people today, and I would hate to think of what would happen if this were to go away, if the law would be repealed without being replaced with something. New Orleans and the greater New Orleans region has worked extremely hard to build access to care. 504 HealthNet has been part of that, and our member organizations have really been phenomenal over the last 10 years. And we now have over 60 sites and serve collectively over 160,000 patients. So a lot of you may have heard of some of the names, Excel, I saw Mike Andre in here earlier. We have St. Thomas, Daughters of Charity. So it's clinics that really focus on opening their doors to everyone. So you can come if you have Medicaid, insurance, if you're uninsured, and people will see you. And that's a really important concept for us to have, that everyone can see a doctor. So here are a few numbers. It's a little small, so I'll talk through them. And this is just in our 4-parish region of Jefferson, Orleans, Clackamas, and St. Bernard. So without the ACA, we would have close to 100,000 people who would suddenly become uninsured overnight. So that's people who get their coverage through the marketplace and people who get their coverage through the Medicaid expansion component. And looking at people specifically in our region, over 11,000 have received primary care visits through through Medicaid, and then breast cancer screening and colon cancer screening. And actually, I apologize, the close to 100,000, that's just Medicaid expansion. That doesn't count the people in the marketplace, and that's around 80,000. So you're looking at about 180,000 people in our region who receive coverage and care through these two programs. So if the ACA is repealed, I think what we'll see is that for people who have insurance even through different means, through their employer, that it will be harder to get care. So essentially, without these programs, we have a decrease in the amount of funding that comes to this area to support UMC Hospital, to support hospital care. Hospitals have to take care of everyone who walks through the ER. So if you have an increase in ER use, costs go up, premiums go up, our taxpayer dollars are not used in an efficient manner, and so you're looking at the state budget being affected, and John will talk a little bit more about some of the state budget issues as well. But I think overall as a community, we really do lose out by suddenly taking away what has been built over the last few years. So yes, you hear in the news, this is not a perfect law. There are improvements that need to be made. Things still need to be changed so that it functions a little bit more stably, a little bit better in terms of your decreasing your cost, your premium cost, that type of thing. We do need some more quality improvements, and I think nationally as a whole, we need to figure out how do we have healthcare costs decrease. But I think repealing without a replacement is very dangerous in the sense that we would have so many people who would not have access to care in the same manner as they do now. And I don't think that that's a direction we want to go in. So thank you for your time.
I think a lot of what I had was redundant, but thank you very much.
We're going to hold all questions until the end, so if you have a question for Susan, just hold on to it. So next we're going to hear from Nola, who's the director of the Louisiana Budget Project, which monitors and reports on state government spending and how it affects Louisiana's low and moderate income families. He's an award-winning journalist, formerly with the New Orleans Times Pick, State Capitol Bureau, where he covered the state budget, healthcare policy, higher ed, and races for Louisiana governor and U.S. Senate.
Thank you so much. My name is John, and the Louisiana Budget Project, we're based in Baton Rouge, and we look at state policies and how they affect low and moderate income families. Susan covered a lot of what I was going to cover, but I think it's really helpful to remember the model that we had in Louisiana prior to 2005, really, which was extremely low levels of Medicaid coverage. We made a policy decision as a state that, Medicaid is a program that is shared between the state and the federal government, and we had extremely low levels of Medicaid coverage. We basically did the bare minimum that the federal government required for you to have a Medicaid program, and instead we dumped a lot of money into a safety net. We in Louisiana were the only state in the country that had a statewide network of charity hospitals, and that's what we had in place before Katrina. And there was a lot of good things about that charity hospital system, but there was a lot that was kind of inefficient. And it basically said, if you were part of the 80% of people in Louisiana who had some kind of health coverage, then you could go wherever that health coverage was accepted. And if you were uninsured, we had 10 hospitals in this state, and those were the hospitals that treated you. And in order to receive money, so-called uncompensated care payments, then you had to go to a charity hospital to be seen. And it was what was called a two-tiered model, and I think it was, God bless the doctors who worked in the charity hospital system, but it was fundamentally unfair, and there's been a recognition that a much better model for delivering health care is to give people coverage that they can use. And coverage is not just important for human dignity, but I think it's extremely important for people's financial well-being. We forget that health care is not just about care, but if you don't have an insurance card, you're not going to go get care when you need it because you're going to get a bill that you can't pay. There was a very important study done a couple of years ago called the Oregon Health Insurance Experiment. And Oregon, a few years ago, they gave out Medicaid coverage via a lottery. So it was completely random who, which low-income person got Medicaid coverage. And so they were able to study what is the effect of when you get, what happens when you get Medicaid coverage. And there were some surprising results in there, but one of the most important results that came out of that is that having Medicaid coverage virtually eliminated catastrophic medical expenses. And that's incredibly important when you remember that in order to be on Medicaid, you have to be poor. I mean, that's the number one criteria for being on Medicaid. You have to be poor. And if you're poor enough to be on Medicaid, then the private health insurance system just doesn't work for you. So, as Susan mentioned, we have two parts of the ACA here in Louisiana. We have the folks who are really poor, and really who earn up to about 138% of the federal poverty level, who now have access to Medicaid health coverage. And there's 374,000 of them in our state, and by the end of this fiscal year, by the time we get to July 1st, the state thinks it's going to be about 450,000 people who are going to get coverage just through that. We have about 214,000 people in Louisiana who are just a little above that poverty line, who are like John, who were able to buy coverage through the exchange. In Louisiana, that comes so that comes to about 588,000 people in Louisiana right now who are benefiting from the Affordable Care Act. That is 1 in 5 working age adults. 1 in 5 adults aged 18 to 64 in Louisiana is in some way covered by the Affordable Care Act. So when you walk down the street and you count off by 5, 1 in 5 is benefiting from this law and has the financial security and the security of knowing that if they have something catastrophic happen to them health-wise, where they have a chronic condition, that they're now being covered. So let's turn to the state budget. Medicaid has always been a shared cost between the state and the federal government. And that's been true since Medicaid started in 1965. And the way Medicaid works is the poorer you are as a state, the higher percentage of the cost the federal government pays. So if you're a rich state, if you're Connecticut, it's 50-50. But here in Louisiana, the feds pay about 63-64% of the cost of Medicaid, and the state puts up the rest. But when Congress passed the Affordable Care Act, they realized that bringing 500,000 people onto the health insurance rolls was going to be a huge cost to the state. So what they did was they made the federal match rate extremely favorable to the state. In fact, the cost was funded 100% by the federal government until December 31st of this year. And starting last week, the state had to start picking up 5% of the cost. So when you look at the Medicaid program as a whole, when you look at nursing home care or care for people with developmental disabilities and all the other things that Medicaid pays for, that cost is funded 37% by the state, 63% by the federal government. But for this expansion population, it is an incredibly good deal financially for the state. It's 5% state funds, 95% federal funds. And so when you look at the state budget, and if any of you follow the state budget, it's a perpetual crisis in Baton Rouge. We've been cutting higher education more than any other state. We've cut child welfare. We've really cut pretty much anything in state government that you could possibly cut has been cut. But the fact that we expanded Medicaid has actually helped the state budget. The savings this year from Medicaid expansion are about $184 million. And the reason for that is simple. It's because we're spending less money supporting the safety net. We're sending less money to hospitals for uncompensated care, and we're spending at this 37% match rate, and we're spending more money on coverage at a 5% match rate. So it's basic, simple math why the state is spending money. There's some other reasons too. When you buy coverage through Medicaid, there are premium taxes that help support this. But the state budget is actually would be $184 million more in the red today had this governor not elected to extend health coverage to 374,000 people. So, so let's talk briefly about the threat to this. What's going on in Washington right now is really absolutely amazing, because you know, the critics of the Affordable Care Act have been saying for 6 years that this is terrible policy. For 6 years, they have not come up with a replacement. And the reason they haven't come up with a replacement, the reason they haven't come up with a plan that is going to cover people and do so at a reasonable cost is because there is no plan. And there's no plan up there that can pass. So what is the plan as far as we think is going to happen? Well, we know that you know, all the candidates, President elect and the Republican Party has promised to repeal the ACA, so they're going to repeal it. And the first step to that is happened yesterday, really, and is going to happen this month. And that is to pass a resolution, and they're going to do it through a budgetary trick, or not a trick, but they're going to do it through a process called reconciliation that manages to avoid a Senate filibuster and repeals this. But they're going to do it, but they're going to put the effective date several years in the future, either 3 or 4 years in the future, to give themselves some time to try to come up with a plan that they haven't been able to come up with for 6 years. And this is going to do a couple of things. It's going to throw the insurance markets into turmoil because insurers really have no idea what's going to happen to these marketplaces, and they have no idea what's going to happen to the mandate that people buy insurance. And so you're going to have all these people who bought coverage through the exchange is going to see their coverage threatened. But so what's the long-range plan? Well, if you look at the next thing that's going to happen after they pass the repeal is there's going to be a budget resolution passed in Congress sometime this summer or this fall. And that budget resolution lays out the budget and the spending levels that the federal government can have over the next 10 years. And under the rules crafted by the Republicans, the budget has to be balanced at the end of 10 years. So now you have a budget resolution, and you have the repeal of the ACA. And so what else has this president-elect promised? He's promised a massive tax cut, and he's promised he's going to build up the military, and he is going to protect Social Security, and he's going to protect Medicare. And then he's going to balance the budget in 10 years. The only way you can do all those things, the only way that the math works is if you take the money out of the Medicaid program. So the long run, and if you look at what Paul Ryan has proposed, the Speaker of the House, they want to transform the Medicaid program from its current structure as an entitlement program, where if you qualify by virtue of your disability or your income, then you are automatically entitled to Medicaid coverage, into a block grant, where each state gets a prescribed amount every year, and this is the money you get, and you do it with it whatever you want, and if it's not enough, tough luck, you're on your own. So we wanted to look at, and this is going to be touted as, well, it gives you more flexibility. The only flexibility this is going to give the state is the flexibility to cut. And it's going to hurt a poor state like Louisiana more than most. Remember, the Medicaid program was designed to help poorer states like us more than states that have more resources at their disposal. So just to look at what it would cost the state to cover the Medicaid expansion population, these 374,000 people who now have secure health coverage at the regular match rate. If the state had to pay 37% of that cost instead of 5% of that cost, the cost to the state would be an additional $855 million. And that's just if they repeal the expansion portion of Medicaid. So we don't know exactly what's going to happen on Capitol Hill. There's a lot of moving parts, but we know that it takes 3 Republican senators, because there's 52 of them, to deny them a repeal vote. And frankly, that's extremely important because if they pass this budget resolution that gets the ball rolling, repealing this, throwing insurance markets into turmoil, and frankly doing great harm to the state budget, which depends so much on these federal dollars to provide the care. So thank you very much for giving me an opportunity to speak, and
Just remember, if you're terrified by anything that Jan just shared about the state budget or healthcare coverage, remember to tweet. We have 2 of those Republican senators here on the board, and their Twitter handles are on the front page of your handout. So please tweet at them using the hashtag #ProtectOurCare. And if you're on Twitter but not good at it like me, you can just retweet the Penn handle is tweet. Someone in here is live tweeting, I believe. Penn Nation. Okay. That's
Action LA.
at PFN_action_LA. Okay. And next, we'll hear from Dr. Angelina Yogi, who is an assistant professor of internal medicine and pediatrics at Tulane School of Medicine. She did her training at Charity Hospital and has worked as a hospitalist at University Hospital and now at University Medical Center. She is the founder and director of the formerly incarcerated Transitions or FIT clinic in New Orleans.
Thank you. Thank you all for being here. I'm going to speak a little bit, so they kind of gave you the overview, and I'm going to make it a little bit more dire because I'm going to speak about a very large population that affects all of us in the United States. So along with healthcare, we've also been talking a lot about mass incarceration and the effects of mass incarceration affects both in the United States and specifically in Louisiana. As many of you know, Louisiana holds the title of having the highest number of people incarcerated in the United States, and as the United States incarcerates more than the rest of the world, we're sort of, by default, one of the largest incarceration capitals of the world. So how does this affect our population? Why am I talking about this now? In the U.S. in general, there's 2.2 million people that are currently incarcerated and another 4.5 million people that are under probation or parole. 95% of people that are currently incarcerated is assumed are going to return back to their communities. In Louisiana and most other states, up until Medicaid expansion, when people were released out of incarceration, they were uninsured. And so you went back into the population, didn't necessarily have insurance. And if you lived in a state like Louisiana, it was very difficult to get insurance. And so you became that pool of uninsured people that both Susan and Jan were talking about. As we heard, being uninsured, drives up healthcare costs in general. People have worse outcomes, and a lot worse outcomes primarily because, as Susan had pointed out earlier, people don't seek healthcare early enough, and so they delay care up until the point where the costs just rev up a lot more. This was an interesting statistic to me. 22%, so nearly a quarter of the people that were eligible for Medicaid under Medicaid expansion were actually justice involved. So it's a really large percentage of the population that we're talking about. So what are some of the things? So justice involved people, so people who have been incarcerated, people who are in jail, people who are on probation or parole are all sort of categorized under justice involved. A lot of the statistics I'm talking about come from the Department of Justice and Bureau of Justice, and they look specifically in prisons and in jails. And when you look at people who are incarcerated, the health risks for people that are incarcerated are far greater than that of the general population. And so here's just, I just kind of threw this up there, but if you look at it, so people who are incarcerated are 5 to 10 times more likely to have infectious diseases like HIV, tuberculosis, and hepatitis. They're 2 to 3 times more likely to have chronic conditions like hypertension, diabetes, and heart disease. And 3 to 4 times more likely to have a serious mental illness. 80% of the people have substance abuse problem, and 50% of the people that are incarcerated oftentimes have a co-occurring illness, which means that they have a mental illness along with substance abuse. And so all of these people, as they are incarcerated, have these health risks and then are released back into the population uninsured and just kind of left to their own devices to go and get their health care. So now what you've done is you have a high incarcerated population, which is a sicker population, again, driving up the healthcare costs. Also, know, as we're focusing more on mass incarceration, there are more releases happening, and so the government, along with the Department of Justice, is sort of looking at how do we, for a variety of reasons, release people earlier. And so we have a larger population of people that are returning home. Many of them are older, many of them went in when they were young, are coming out with chronic diseases or just not having had any screening while they were incarcerated, and so undiagnosed diseases. So what happens to people when they are released? So there were a couple of studies that were done. So one of the things that's very striking is the first 2 weeks after release, there's a 12 times increased risk of mortality. So that means that even if you were a 50-year-old man with, diabetes and the same socioeconomic status and racial makeup, if you were incarcerated in the first 2 weeks after release, you have a 12 times increased risk of mortality. There's a whole host of reasons for that, and we can get into some specifics later if anybody has questions. There's also an increased risk of hospitalization and a greatly increased risk of utilization of emergency rooms. This is in Louisiana and throughout the country, and so all of that just increases the utilization of healthcare costs. There's also some, talk about this a little bit later. So bringing it back down to Louisiana, so as we said, Louisiana has one of the highest rates of incarceration. 40% of people in Louisiana currently are incarcerated, so that's almost 1.5% of the population. And 90% or greater of the people who are currently released out of incarceration are uninsured. So this is just some of the statistics of the healthcare burden. This is while people are incarcerated, so about 30% of the population that is currently incarcerated has high blood pressure, 10% has hepatitis C, 7% diabetes, and kind of go down the list, asthma, COPD, HIV, heart disease, and other kinds of hepatitis. 25% of the population is over the age of 50, and I keep bringing that up because once you're over the age of 50, as many of you know, that's when sort of health screenings, regular health screenings start, and so that's an undiagnosed 25% is over the age of 50. So the FIT clinic, so the FIT clinic was started, it's a formerly incarcerated transitions clinic, and it was started about a year and a half ago in partnership with Vogue. And the impetus for starting the clinic was that we were recognizing there were a lot of people who were coming out of incarceration who were uninsured, who were coming back to Orleans Parish. So 50% of people who were released in the state of Louisiana returned back to Orleans Parish. And so as they were coming back with these chronic conditions, with undiagnosed or diagnosed diseases, they were unable to procure medications, they were unable to access health care for a variety of reasons. So this is post-Katrina. Charity Hospital no longer exists, the safety net system no longer exists, and people were unsure of where to go to get care. And so we started this clinic really to try to bridge that gap, to identify the people that fall into that 2 weeks post-release, increased mortality, increased hospitalization, increased ER uses. And so we created a clinic that was going to be culturally sensitive and designed specifically for these patients to help them transition back into how do I take care of my own health, along with how do I provide all of these other services that are required for transitioning back to the outside. One of the big things that we do when patients come in is to ensure that they are able to be enrolled in insurance. And so with Medicaid expansion, that has been incredibly useful because, as you know, greater than 90% of the people are uninsured, and almost 100% of the people are going to be Medicaid eligible. And so one of the things we've been able to do is to get them insured earlier as they come in. This really quickly, so this is from our clinic. We kind of talked about what the DOC statistics were when they were incarcerated. This is the data that we've collected so far. So majority of the people that we see, 80% are men, 20% are women. Average age is 48 years. And then hypertension, a lot of mental illness. So I just put anxiety and depression, but a lot of mental illness, substance abuse, diabetes, hepatitis C, stroke, and ischemic heart disease. So in terms of what Louisiana Medicaid currently pays for with the incarcerated population is that if someone is incarcerated currently, so funding for people that are within the prison system, and speak specifically about prisons and leave OPP out of it because it's a whole different funding stream. But people who are within the DOC prison system, their care comes out of the state budget and it's given to the prisons sort of as a whole for them to take care of their own patients. And this has changed since we went from charity hospital to public-private partnership. Before the money was sent to the public hospitals were responsible for caring for the prisoners that came to them. Now the money went to the prisons itself. Prisons now take care of what they can. What they can't take care of, they send them to the hospitals. Louisiana Medicaid will pay for that hospital care if patients are in the hospital for greater than 1 day. So you have to be there for 24 hours for Medicaid to pay for it. We in this state currently don't enroll people prior to release. That's something that is being worked on, is to get them Medicaid enrollment prior to release. We haven't done it, but there are other states that have done it, and I have a few statistics of what they've shown with Medicaid expansion. So this is a really busy slide, but a lot of the stuff where people get Medicaid at release or enrolled in Medicaid, what they have found is that the recidivism rate decreases. So the time between either fewer number are going back in, or the time between going back into incarceration is much longer. And that's just controlling for everything and just looking at acquisition of Medicaid, having insurance, and that's it. They looked at healthcare costs. So Colorado, when they expanded their Medicaid, they looked at people who were coming out of incarceration that had substance abuse issues. And when Medicaid started to cover substance abuse issues for them, they ended up over 2 years saving $3.5 million. So that's, I know that we had a much bigger number, but this is looking at a very, very, very minute population. So incarcerated substance abuse issues, and that was 3.5 million that they saved. This last statistic, so they had community health workers that were getting paid for, that helped people transition out of the incarceration system into primary care, helped them get their medications, helped them make sure that they had subspecialty care referrals, and they decreased their recidivism rate over 5 years from 46% to 25%. So as we think about what happens with the Affordable Care Act and whether or not it gets repealed, and we talk about the existing population and how it affects them, but there's a whole new population of people that we've been really excited they're going to be able to get care, and maybe get care for the first time in their lives, that are also going to be at risk. And it affects not just their health care immediately, but also all of these things, incarceration, recidivism rates, the cost to society that goes beyond health care is going to be exponential.
Thank you for our panel. Again, we're going to hold Q&A until the very end. So next we're going to hear from Thea Crane, who is an attorney here in New Orleans, who moved down here for law school and says she refused to leave.
I guess this is the personal statement section of leaving. So, as she said, I'm an attorney here in town. I've been here for almost 5 years. While I was 19 years old, I had my first stroke. I had another when I was 23 during law school. And they ran the gamut of tests, couldn't find anything. So basically, it made me uninsurable. Not only did they know that I had a history of stroke, they also know that they can't pinpoint how to treat or what could prevent me from having any more. So that means that they aren't really willing to take that gamble. Fortunately, I count myself lucky in a couple of respects. One, both of those incidents happened before I was booted from my parents' insurance. So I was covered at that time. But I panicked a little bit until the Affordable Care Act came in because I knew I would get insurance. Second, I count myself lucky because as of now, I made a really great recovery. I have no real lasting damage except for memory damage. And I'm not currently on any medications or anything like that due to strokes. So currently, I'm pretty good to go and I'm lucky that way. But I also have access to care right now should something happen. And it's almost certain that I'll need some kind of care because of that in the future. So like a lot of other people, My biggest problem, I guess, is, as mentioned before, there's no plan currently presented to the public, just, blanket statements of there's going to be a school transition, which it'd be nice to see what the plan would be and see if it's actually going to be effective for not only me, but millions of other people that are in the same boat.
Okay, and so now is the time when we take out our cell phones and get on social media. So the plan is to have a Twitter storm. Raise your hands if you know what that is. All right, okay, you guys are gonna be the leaders. Really, you could jump on Twitter or Facebook and just shoot one quick message, or even simply retweet one of the tweets from at PSN_action_LA. It would be a huge help, and make sure to include both senators' handles. So they're also really simple, at John Kennedy LA and at Bill Cassidy. It's really important that they know that this is happening and that all of you are in this room because you're concerned. And even if they do plan to move forward with repeal, we have to demand that they tell us what's going to replace it. Even if they say they're going to delay it for 2 or 4 years, we still deserve to know what's going to happen. I don't think that's fair to anyone.
Is there any way that you can post whatever that was on the screen?
It's also on, their handles are on this first bullet point on your handout.
We ran out of the handouts though,
Okay,
so.
sorry.
I have an extra one. Somebody won't have it.
That's not disconnected.
You want to repeat the repeat the handle, please?
Yeah, it's at PSN_action_LA.
Oh, yes. Okay.
So yeah, just take a minute or two to send those tweets. Facebook works too, they're linked together, so
Are we tweeting to cancel page or are we
you can
tweeting to-
retweet what this handle is tweeting if you don't want to create your own tweet. Or you can just create your own tweet using the two handles for our senators and the hashtag #ProtectOurCare. And if you don't use any of those fancy gadgets, tomorrow morning, first thing, you can give them a call the old-fashioned way. These are the 3 office numbers, 2 of our senators and 1 of our congressmen. You can call, ask them to talk to their healthcare staffer, and send along the message that you're concerned.
I think it's really important for people to actually call and email and write letters. You talk and you hear from staffers of what actually makes a difference. And flooding the offices, particularly the local offices, with phone calls is really effective. And I'm not really a social media person personally. I know it's important. I know it's a great tool with advocacy and campaigns. But it always makes me feel like, what else can I do? And so I think tonight for the call to action is really tomorrow or sometime next week, make some phone calls. Recruit 3 other people of your friends or family to make some phone calls as well. On your lunch break, when you're driving to work on a hands-free set, something, make those calls. And you can go online to the websites for the individual senators and representatives, and you can fill out a form to email them as well. And I think everyone has networks here, so maybe someone personally knows they grew up with one of the representatives. However you can get that message of how important coverage is, and that no repeal without replacement. And the other message is to really protect Medicaid. Jan talked a little bit about the block grant issue and really sort of the concept of what cuts would really do. And if we do have block grants and we do have cuts, it means the expansion population will no longer have coverage because the state can't afford it, frankly. And so how do we as a community react and try and really generate that energy around saying, hey, this is important. We make those phone calls, write those letters, snail mail, email, Twitter, Facebook, posts, whatever you need. And we do have some sheets I think out on the table that have some sample scripts if you're at a loss for words and you want some information there, we can help with that. But I think it really is important to try to not only do it yourself, but then ask 3 friends or family members to also reach out and just try to say how important this really is.
Yeah, if you've signed up outside the door with your email, which I think most of you have, you'll continue to receive action alerts, and so that you know when big things are moving or happening in Congress, when decisions are being made. Those are the times to really respond and call, because if they don't hear from you, they don't know. And so it's really important that they hear from constituents that elected them.
So is there somebody in these offices who answers the phone?
Yeah.
Yes.
Should be, yes.
Some poor
Will
schmuck
you guys
is
be
answering the
notifying us
phone.
when Steve Scalise or any of the senators will be having town hall meetings?
That can happen, for sure.
Bill Cassidy is doing a Facebook town hall tomorrow.
You go on, if whoever's on Facebook, just go to Bill Cassidy, I think it's just Bill Cassidy, it's his Facebook page. And I'm not really sure how a live town hall works on Facebook, but what it said is,
It's easy.
please pose a question. So I don't know if he's just gonna cherry pick the right questions, but if we, a big chunk of you go and just pose questions, right, and make it clear that you want them to protect the ACA, not appeal the ACA. And pose, one of these questions. There's a lot of good information. I think, even if he doesn't address it in his live town hall, then at least he knows that there's a strong constituency out there. The other thing about Bill Cassidy is that he was recently, I think it was just yesterday, appointed to the Senate Finance Committee, which is an incredibly important committee. But that's where a lot of this, and Jan, you're probably the expert on how DC works, not just Louisiana. But Bill Cassidy is not just our senator, but he's a very important target now, right? If you want to protect the ACA, your friends, your family, in Louisiana, but all over this country, can contact Bill Cassidy, right? To say, and he's gonna fool people because he's a doctor and pretends like he knows everything about healthcare and whatever, but he needs to really get that barrage of calls during the whole month, right? Because this is gonna move very, very, very quickly.
The town hall is at 3:30 tomorrow on Facebook.
Can you post it into the event page for people?
Yeah, that's good.
I was gonna post it in the Twitter so you can see.
And now, you already kind of started, but now is the time for public comment or questions. So if you have a story you want to share, your questions for the panelists, or just something you want to share with the group,